Hello friends, we are going to discuss thoracoscopic decortication for empyema in pediatric patient, particularly two-port technique. 6 years female child was presented with cough, fever and tachypnea for 8 days. ICD was placed on admission which drained about 450 cc frank pus, but persistent fever spikes were present. Chest X-ray shows haziness in left hemithorax with obliteration of the CP angle, which suggests empyema. Post ICD insertion X-ray shows haziness in peripheral part of the lung along with rib crowding. CECT chest showed lobar pneumonia with loculated collection with thickened pleural peel. There is evidence of rib crowding along with pleural split sign. We are using two ports only. Right lateral decubitus position is given. First port placed in mid-axillary line in 4th intercostal space. Second port placed in anterior axillary line in 7th intercostal space. On thoracoscopy, we can appreciate lot of pus flecks within the thoracic cavity. Pus flecks are present over the lung surface, diaphragmatic surface and parietal wall. Our target is to remove all the pus flecks within the thoracic cavity as well as parietal peel and visceral peel. Also, we have to remove pus flecks which are present over the diaphragmatic surface. All these things will help in inflation of the lung properly and prevent further complications. We can use various instruments for removal of the pus flecks and peel, such as sponge holding forceps, long curved artery forceps, Cocker's forceps, or latestly empyema forceps can also be used to do the job. Now we can see we are removing the thick parietal peel using sponge holding forceps by twisting and rotating movement. We have to perform repeated suctioning using Yankur's suction tip as there is lot of ooze from the inflamed surfaces. We can see pus coming out after breaking the septations. We have to keep on removing all the pus flakes and peel from all the surfaces. In between, we have to interchange the position of working port and camera port. It will help to remove the peel from all the corners within the cavity. While performing VATS decortication or thoracoscopic decortication, initially the vision is not good and space is also limited, but as we progress in surgery, we get more space and clearer vision. VATS decortication is much more feasible during second phase of empyema, that is fibrinopurulent phase, which extends from 3rd to 14th day of the illness. Removal of the parietal and visceral peel becomes extremely difficult in 3rd phase, that is organized phase. It usually starts after 14th day of the illness. In between, we can give warm saline wash so that small pus flakes will be suctioned out easily using Yankur's suction. We are using grasper forceps to remove the pus flakes which are present far away from the port site. Now we are removing parietal peel using sponge holding forceps. After grasping the peel, we are doing twisting movement so that it will be stripped off from the chest wall. Now we are removing pus flex from the diaphragmatic surface. Lastly, we have to ensure removal of the visceral peel. This is the fissure between two lobes. There is a slight pus which is coming from one of the lobe, which suggests it is a necrotizing pneumonia in that particular part. Peel is sent for the histopathological examination. Post-op chest X-ray shows good lung expansion along with acid in situ. Post-operatively, vigorous chest physiotherapy, incentive spirometry and high protein diet are important. Higher antibiotics were continued. ICD was removed on post-op day 5. Patient recovered uneventfully. Thank you so much.